Hello, this is Doug Coplen. Can people hear me?
Yes, Doug, we can hear you.
Okay. I'm so sorry about this nonsense, but we will get through this lecture as best we can. So we're going to talk about duplication anomalies, and I think the first slide is my disclosure slide that says I have nothing to disclose. You can go to the next slide, and then the next slide. So just a little bit of embryology at first. So as we all know, if there's no ureteral bud, you're going to have renal agenesis. If there's ureteral bud that does not canalize, then you're going to end up with some form of multicystic dysplastic kidney or dysplastic kidney. If there's an early bifurcation, you end up with a bifid collecting system. And as is shown on the bottom, if you have two buds, then you're going to have a complete ureteral duplication. So next slide. The Trigon forms because the bud spreads out and expands and forms the base of the bladder. And this becomes, I think, important, and we'll talk a little bit later about how the embryology of duplicated ureters, ureteroceles, and ectopic ureters form. So the mesonephric, the UG sinus absorbs the Wolffian duct distal to the ureteric bud, and that's what becomes the Trigon. The ureteric bud's more cephalad and lateral, and then the Wolffian duct moves caudal and medially and becomes the ejaculatory duct. Next. So the Weigert-Meyer rule, I think, may be mostly important for board questions. So the most caudal orifice is obviously the lower part of the kidney, and the most cranial orifice is the upper pole of the kidney. And as those are absorbed into the Trigon, the most caudal orifice, or the most caudal bud, again, migrates cephalad and lateral, and the most cranial bud moves caudally. So next slide. When you have a ureteral duplication, the lateral orifice is going to be to the lower pole of the kidney, typically has a shorter intravesical segment, so there's a higher risk of reflux. And there's also, we'll discuss later, a higher incidence of ureteropelvic junction obstruction. The medial orifice is the upper pole of the kidney, and it's more likely obstructed distally, either to secondary to an ectopic ureter or a ureterocele. Next slide. So this is a diagram out of Douglas Stevens' book, and I think it's important in duplications because, as you can see, if you have a bud that's in a normal location on the Wolffian duct, like A, E, F, or G, or A, E, or F, then it's going to induce the metanephric mesenchyme normally, and you're going to have more normal kidney. However, if you have a very caudal bud that's going to give you high-grade reflux, then it's more likely that the kidney is not going to form normally. And similarly, if you have H, which would be a very cephalad bud, the upper pole of the kidney may not develop normally. Next slide. So this is just a kid with congenital high-grade reflux and a crappy little kidney. And why is that? It's because the bud was too caudal on the Wolffian duct and did not induce the mesenchyme normally. Next slide. So these are three pictures of duplications. The one on the left is what would be most commonly identified with duplication is both ureteral orifices are in the bladder, and there's not obstruction, and there's not reflux. The middle one being a ureterocele, and the second one is an ectopic ureter. The third one, the one on the far right, is pretty easy to explain based upon the Wolffian duct and migration of the Wolffian duct distally. However, why do ureteroceles form? Why is a ureterocele different than an ectopic ureter when they're both abnormal buds, but they're somehow embryologically different? So Chihuahua, I think, is what I was taught when I was a resident, that it's Chihuahua's membrane, that the next slide, sorry. The membrane obstructs and then balloons out into the bladder, and that's how a ureterocele forms. It's just a ballooning of the ureteral mucosa out into the bladder. I don't read German, so I don't know the exact specifics of the article that was written, but I think that does not hold water for a lot of ureteroceles that we see. Next slide. So this is a duplication anomaly, and the upper pole of the kidney is multicystic dysplastic. So that means that the ureter did not canalize. It means the kidney never made urine. Well, if the kidney never made urine, how did it form this ureterocele? And what was the hydrostatic pressure that caused this ureterocele to form that you can see on the ultrasound and on the cystogram film, the static film? Next slide. Similarly, it's been described the ureterocele disproportion. So in this situation, you have on the right side of this figure from the Journal of Radiology in 1989, you see a large ureterocele in the bladder, but very little associated renal parenchyma. So again, that renal parenchyma was not making urine that would cause this to distend. So I think Emil Tanago, who was at UCSF, had a reasonable understanding of what might be happening in duplications. And this is a pretty good article from 1976 in Urology. I would focus on the right-sided figure here. And his thought was that the bud was so far cephalad, and the expansion, the expansion that I talked about earlier that caused the Trigon to form actually started happening extravesically. And so then it started to balloon out and then integrated itself into the Trigon and the bladder. And so I think for a lot of these, if you think about how things are, there's a big hole in the floor of the bladder and the Trigon. The Trigon itself did not form normally in a lot of patients with ureteroceles, especially the ectopic ureteroceles. And so I think in those situations, the Chihuahua's membrane theory does not hold, and then I think it's more of a ureterobud and trigonal developmental abnormality. Next slide. So obviously most duplications nowadays are identified during pregnancy. And so this is images of a fetal ultrasound. There's actually a duplication anomaly on both sides. I think if you look at the upper right image, you can see that the upper pole has grade 2 or 3 dilation. The lower pole has minimal renal pelvic dilation. The one on the left on the upper side, you can see there's a duplication on both sides. And then in the middle on the bottom, you see a ureterocele in the bladder. So the vast majority of these are detected during pregnancy. I think some of them, all that's identified prenatally is a hydroureteronephrosis that the obstetricians maybe aren't good enough to tell it's a duplication, but they're good enough to identify there's an abnormality that then can be acted on postnatally. Next slide. The next most common would be with an infection. So this is just a little baby that has presented with infection, and you can see a duplication with upper pole pyonephrosis with debris in the dilated upper pole collecting system, and then a little bit of dilation in the lower pole. Next slide. Some kids you would find just they present with a urinary tract infection, and maybe they had some hydronephrosis, and depending on how you interpret the AAP UTI guidelines, you would get a cystogram. So again, this is a cystogram and the drooping lily on both sides with lower pole reflux. You can see there's discrepant reflux into the upper pole on the left side, and typically that would mean that those orifices are very close together in the bladder, because upper pole reflux typically doesn't occur unless it's an ectopic ureter, and given that this is a pretty delicate system, that's probably not an ectopic ureter. Next slide. So this is an IVP, which I think probably most of the current fellows don't see much of this. And what this shows is non-function of the lower pole on the right side in a duplication, a single system on the other side. On the films on the right, I think that's filling because the bladder is full, and there's actually then reflux to the lower pole that is pacifying the non-functioning system. Next slide. So sometimes these present with pain. So this is a child with abdominal pain, nausea, vomiting, and a Diedel's crisis. And you can see on this CAT scan that the lower pole of the system, there's pilocalyexis with cortical thinning, but that the upper pole is normal. And then this next slide is just imaging from Campbell's showing the lower pole duplication with a UPJ obstruction. And in my experience, most of these occur when there is an incomplete duplication and not necessarily a crossing vessel, sometimes just a fixed abnormality, but I think this one looks like there's probably a crossing vessel. And the way to correct this, the easiest way to correct this is to do a pilo-ureterostomy. So you take the lower pole renal pelvis and you sew it to the normal caliber upper ureter. Now, the other point I'll make from this is that since the upper pole of the kidney of a duplicated system typically is just a single calyx, UPJ obstruction to the upper pole, which is very, very rare. I mean, I've seen it a couple times in my career, but since there's no renal pelvis and only a single calyx, it's very difficult to have an upper pole UPJ. Next slide. And the next slide. So now we're going to talk about ureterocele. So the terminology is intravesical versus ectopic as opposed to intravesical versus extravesical. And ectopic just means that part of the ureterocele extends past the bladder neck into the urethra. So some portion of it is located permanently at the bladder neck or in the urethra. Next slide. So an intravesical ureterocele, you can't really tell from the static view whether it's intravesical or not. But I think one of the common findings would be that on a voiding view, if you look at the film on the upper right, during the voiding view, there is not eversion or prolapse of the ureterocele. So intravesical ureteroceles typically have more normal trigonal development and don't evert. And then endoscopically, you can see that the ureterocele went past the bladder neck with the scope here, and the ureterocele is in the bladder neck, or in the bladder. Next slide. So an ectopic ureterocele, again, is something that extends distal to the bladder neck. So the bladder neck, you can see the bladder opening is to the left on the view on the left, and then with turning the flow on, the ureterocele partially decompresses, and you can see the bladder's off in the distance. Next slide. A ceco-ureterocele is difficult endoscopically to tell from I guess the standard ectopic ureterocele, but it's a long blind ending segment that extends down into the urethra, and the ureterocele orifice is actually in the bladder. The problem is that the anatomy is oftentimes so distorted that you don't actually find the orifice inside the bladder. And then a sphincteric ureterocele is one where there's a large opening just distal to the sphincter. So the view on the left, this is the next slide, sorry, the view on the left shows the bladder neck relatively coapted, and then just around about the 6 or 7 o'clock position, you can see the opening to the ureterocele. When you turn the flow on the cystoscope, then the ureterocele opens up, and you can see that there's a large capacious opening. And I think next slide, if you have a patient with the ureterocele and they cannulate the ureter inadvertently during the cystogram, it's probably one of these sphincteric ureteroceles. So on this image here, you can see the small ureterocele is opacified with the linear round filling defect at the base of the bladder, and then the radiologists have inadvertently done a retrograde to the upper pole of the left kidney. Next slide. So this is an article out of Australia. Sudita Sen is actually a pediatric surgeon who I met when I was on a mission trip in Vellore, India. He's a great guy. And the functional studies here on IVP, so which is obviously not something we do now, but I think it's the best large study that sort of evaluated function and reflux in children with duplicated systems and ureterocele. So you can see, if you look at the function, that the ureterocele moiety typically has very poor function. And again, this is IVP, so it probably underestimates what's there, but even in an ideal situation with a duplication, the upper part of that kidney probably only does 1/3 of the function on that side. Typically, the contralateral kidney and the ipsilateral lower pole have reasonable function, although oftentimes the lower pole on that has higher grade reflux, so then that kidney didn't form either. And so then again, if you look to the right side of this table, the incidence of reflux into the ureterocele spontaneously is pretty rare. Ipsilateral lower pole reflux happens over 50% of the time, and contralateral reflux happens pretty commonly. Next slide. So just as comparison, again, if you have a single system ureterocele, the function's typically good for the ureterocele moiety. In a duplex, it's poor. The dilation with a single system is usually mild to moderate. Duplex is typically pretty severe. And again, ipsilateral reflux is very rare in a single system ureterocele, but pretty common in duplex ureteroceles. Next slide. So how about bladder function in children with ureteroceles? There's a fair number of studies in the literature. This may be the best one because they did histories, uroflows, and cystometries on children before and after they'd had procedures. And basically they showed that bladder dysfunction is present at diagnosis, and it really doesn't seem to be affected by surgery in any significant way, although certainly some of these, as we'll talk later, are pretty complex abnormalities. And on that basis, surgery can, perhaps cause some iatrogenic issues. Next slide. So why is it that ureteroceles have problems with continence? Well, again, this is the sphincteric ureterocele I showed you earlier. You can sort of see, yeah, the bladder neck looks pretty well coapted there on the left side, but boy, it's a pretty big capacious bladder neck on the right. And similarly, this is a little baby with a UTI and a SICO. So this is a SICO ureterocele that I think spontaneously ruptured in utero. So the top two pictures are cystograms, and that's the appearance of the urethra and the bladder neck before anything had been done to the patient other than doing a cystogram. And then endoscopically, there's all these little, on the bottom, the bladder neck opening is on the left. All these other things are little spontaneous fenestrations that were formed, I guess, spontaneously somehow in utero as it ruptured. And it's not some ureterocele incision gone awry, as you might think. Next slide. So how about hypertension in these children? So Doug Hoosman at Mayo evaluated children that had ureteroceles and duplications, and you can see here that about 9% of the patients had hypertension with long-term follow-up, and the population that had partial nephrectomy was obviously much larger than the one that had incision, but the hypertension was the same in both groups. So I think the conclusion from that would be that much of this was probably related to hypertension and not iatrogenic injury to the lower pole vasculature by doing the partial nephrectomy. Next slide. So what are the management options for ureteroceles and duplications? Well, antibiotic prophylaxis and observation, incision, partial nephrectomy, ureterostomy, ureteropylostomy, and complete reconstruction. And the reconstruction may involve ureteral tapering or imbrication, and again, we'll talk about that a little bit later. Next slide. So when I was a fellow in Philadelphia in 1993-94, pretty much the practice was when we had a newborn with a ureterocele, it was an urgent thing. We almost treated it like a valve patient, that we had to incise this thing because, by golly, they were at huge risk for infection, and if we didn't incise it on an urgent basis, we were placing them at risk. And I think that practice has probably changed. I mean, there certainly, we'll talk of indications to urgently incise a ureterocele, but this study out of Texas and Mayo, again, they had patients that they immediately incised, and compared to ones that had delayed surgery, I think most of them were upper pole partial nephrectomies, and basically all of them on prophylaxis, and the number of breakthrough infections was pretty much the same. So I think you don't necessarily need to put a 2-3 day old to sleep to incise the ureterocele if there's not an absolute indication to do it. Next slide. So can we observe some? So again, these are the pictures I showed earlier of the multicystic dysplastic kidney, ureterocele with no dilated ureter and no reflux. And what happens if you observe a multicystic dysplastic kidney? The multicystic dysplastic kidney, next slide, involutes. So you can see initial, maybe a year later, and in a couple of years of age, you got a smaller kidney with a little bit of an echogenic upper pole. And so we looked at that almost 20 years ago, and we identified 8 patients that had multicystic dysplasia and ureterocele. Some of them had single systems, some have duplications. In all cases, the multicystic dysplastic kidney involuted, and in most of them, the ureterocele collapsed, or some of the ureterocele collapsed. Since the ureteroceles were relatively small and weren't causing voiding issues, just no reason to intervene. Gil Rushton, next slide, looked at 13 patients, and they either had non-obstructive hydronephrosis as determined by a MAG-3 scan or a multicystic dysplastic kidney. And the reflux resolved in all cases. they did do surgery in 4 out of the 13 patients. Next slide. In England, they followed 14 patients, and if they had very poor upper pole function, didn't have obstruction of the lower pole, ipsilateral low-grade reflux, no bladder outlet obstruction, prophylaxis until toilet training, and none required surgical intervention. And I think there was another large series by Mike Leonard out of Ottawa that concerned the same thing. So basically, some ureteroceles never require treatment, and the population that I think fits are going to be the ones that have absence of hydroureter obstruction, they have multicystic dysplasia, or absent or low-grade reflux. Next slide. So incision in 1968, D.I. Williams thought that unroofing ureteroceles was only advocated as a drainage procedure for an infected system prior to a definitive procedure. Next slide. Ed Tank reported unroofing of ureterocele. So what he did is he just took a resectoscope loop and unroofed the ureterocele in the bladder, and he caused reflux in all of those patients. And in the 20 patients that had crappy function and reflux, he did nephrectomies. And in the 20 that had somewhat improved function, only 2 of those 20 patients that had iatrogenic reflux into the ureterocele moiety actually had, he thought, clinical indications for intervention. Montfort, in 1985, Howard described making a very small incision, this is the next slide, at the bladder base, and described his experience in 3 patients. So the next slide shows intravesical ureterocele, and then a bug bee, and a small little puncture hole with maybe some adjacent thermal injury that the hole is actually going to be bigger than the 3-inch bug bee electrode. And so he described that this was going to be reproducibly decompress this, and yes, the concern was whether that they would develop reflux. Next slide. So how do you incise a ectopic ureterocele? So this is an ectopic ureterocele. Oftentimes you cannot find the opening, but in this one I found the opening distally, and you can see I took a resectoscope loop in there and then basically incised that so that it would drain. There have been great, I guess there's several articles that talk about if you puncture a ureterocele like this at the level of the bladder neck, that you need to make a second incision down in the urethra so that you don't get a windsock or obstructive flap. I've not actually seen that as a clinical issue, and so I'm not 100% sure in my own mind whether that needs to be done. Next slide. For a sphincteric ureterocele, what you want to do is you want to open up the opening. You're going to make it bigger, and it's already big, but this ureterocele is obstructed when the bladder neck is closed. It's not obstructed when the child voids. So you want to extend the opening into the bladder. So you can see there I'm taking a resectoscope loop and extending that into the bladder. Next slide. So in Germany and then subsequently in Oklahoma, they talked about using a laser to make a watering can puncture, putting innumerable holes in the wall of the ureterocele using a small laser fiber, and thought that there was a lower incidence of iatrogenic reflux and then a lower incidence of requiring subsequent bladder reconstruction. Patty Dewan in Australia, next slide, evaluated several different ureterocele incision techniques, and I think their conclusion was probably right, that the result reflects the complex anatomy and they're all different, and it's not necessarily the technique. I think it's the anatomy that's utilized. Next slide. So the advantages of neonatal incision are its minimal morbidity. There's some thought it might recover function, but again, like I said earlier, there's typically very little function associated with the upper pole moiety or the ureterocele moiety, at least in a duplex system. And I think there's good evidence that if you have the non-hydrophobic or decompressed upper pole, the non-functioning segments really don't require treatment. There's lots of instances where we leave poorly functioning kidneys in. If they're not hydrophobic, they're not an infection, you don't necessarily need to remove it. Next slide. So you manage iatrogenic reflux expectantly. Infections on preventive antibiotics or like anything else, they're unlikely. And then you reconstruct for clinical indications. So the next slide, this is again, an intravenous pyelogram. So the pyelogram on the left would be pre-incision. So you show no function of the upper pole when you see the ureterocele down in the bladder. Now, my mentor, Howard Snyder, told me, well, gosh, look at this. It's such great. Look how well that upper pole is functioning after the incision on the film on the right. My guess is it's nicely decompressed, but that there's actually reflux up into that moiety that's causing it to opacify so well. But I think it's still what you would like to see. You would like to see the hydronephrotic upper pole decrease in size. Again, you might have reflux. Next slide. So what happens when you incise a ureterocele that's intravesical? So again, the decompression is typically very successful. You get an ultrasound a month or two later, and the hydronephrosis is markedly decreased. At some point down the line, you're going to get a cystogram to see if there's reflux into the upper pole moiety. And in those situations, it's probably a little bit less likely that that reflux is going to go away. A lot of these studies that are on this screen are older, and so I think you can see that the reflux and the subsequent surgery pretty much correlated 100%. And so it may have been back when the presence of reflux equaled surgery, whereas that may change now, may have changed nowadays. Next slide. So if you do a duplex, though, obviously the success is a little bit less because they're more complex. The incision, the incidence of iatrogenic reflux is much higher. And again, I think that's because the Trigon is not as well supported, so the ureter is not as well supported. And the subsequent surgery, again, was probably driven by the presence of reflux and maybe not 100% by the presence of breakthrough infections. But at least in these series, the success was pretty good. Like I said, the ectopic ureterocele is much higher risk of reflux. Next slide. So what are specific indications for incision? Well, uncontrolled sepsis and bladder outlet obstruction. Next slide. So again, a child like this, I think if you watched Larry Baskin's urologic emergencies, his practice case was this exact case. He punctured your ureterocele and there's a bunch of pus coming out of it. That's clearly an indication for ureterocele incision. You don't want to be doing a percutaneous nephrostomy seems like a crazy concept because it's not definitive, and most little babies aren't going to handle a nephrostomy tube very well, and you're not going to do in an acutely infected patient a partial nephrectomy. Next slide. Bladder outlet obstruction. So this cystogram, this is a static view on the left and then voiding views on the right. So you can see that there's bilateral reflux. You can see that the bladder is somewhat trabeculated in appearance and that the ureterocele balls valves down and is actually obstructing the bladder neck. I think any child with a ureterocele where there's ipsilateral lower pole hydronephrosis and contralateral hydronephrosis, you have to be in the back of your mind think that there must be some degree of bladder outlet obstruction and have to consider earlier as opposed to later intervention. Next slide. So this is a prolapsed ureterocele on the very top picture on the left there. And it's a pretty classic thing if you see it in the emergency room. There's not a lot of introital masses that look like this. It's inflamed in appearance. Imperfect hymen wouldn't be inflamed in appearance like this. A Skene's duct cyst is more opalescent and again not inflamed. It would show up in the newborn period. So you can see, you can confirm it's ureterocele by getting an ultrasound that shows obviously a duplication and a hydrocele or a hydronephrosis. This management I find is pretty easy. Every child I've seen like this, I've taken a 14 or a 16 gauge angiocath at the bedside and stuck it in the ureterocele and aspirated out the pus. And the picture you see of the baby is what the bottom looked like the next morning. And the images down below are probably what it looks like 3 or 4 months later. So you're doing an incision, and yes, that's kind of necrotic tissue. And I think in this patient, obviously there was, upper pole reflux after doing this, but these kids are sick as a dog. Next slide. So you have to be aware of the pseudo-ureterocele. So pseudo-ureterocele is a dilated ureter that's pushing on the posterior wall of the bladder and deforming it to give the look of ureterocele. Sometimes on an ultrasound, it's hard to tell in a little baby because the bladder wall is not very thick and the ureterocele wall is not very thick. And so sometimes it's difficult to tell the difference. But I think you have to look closely at it. On a CAT scan, it's easier. You can see on the bottom images on the CAT scan, you can see the bladder wall is contiguous around this, and this is just a dilated ureter in a child with hydronephrosis. The problem with this is if you try to incise this through the detrusor muscle, it's not going to succeed because the detrusor muscle is, it's detrusor muscle and it's thick, and any hole you put in there is going to close off unless you make a huge unroofing incision. So I think usually it's pretty clear what a ureterocele is and what it isn't. But again, from these pictures, you can see sometimes it's ureterocele. Next slide. So the upper tract or simplified approach is removal or diversion of the hydronephrotic moiety without risk of bladder level surgery. And it reliably leaves obstruction. Obviously, if you remove the upper pole moiety, then it's not obstructed anymore. And then you defer bladder level intervention at a later time as needed. And the proponents of the upper tract approach are it avoids the potentially difficult bladder neck surgery. So if you think back to the, kid that I showed with the sphincteric ureterocele, if in that situation you could remove the upper pole and decompress it and they didn't have reflux, then you've avoided operating and perhaps causing some iatrogenic injury to the bladder neck. Next slide. So this is just a little history. So Frederick Foley is the first one to describe a ureter or ureterostomy. The weird thing is he was doing this because there was an obstructed distal ureteral stone in one ureter. But if you go back to the Journal of Urology in 1928, you'll see this. So what are the outcomes after ureteropilostomy? Well, I think, again, it reproducibly decompresses the upper tract. You're diverting the urine. I think there's always some concerns about yo-yo reflux with, I think, the paradoxical reflux up the other moiety, which I think doesn't happen very frequently. The most common complication is not obstruction or injury to the recipient ureter, but transient leak. So if you do a partial nephrectomy, what do you remove the upper pole moiety, the bladder decompresses, you can see the lower right, this is the next slide, sorry. You see perhaps a little residual cyst or seroma that you left behind. Next slide. So it's unclear based on the literature what the risk to the lower pole is doing an upper pole partial nephrectomy in an infant. I think the vessels are very delicate, and I have some suspicion that the injuries are maybe higher than reported, and that's led to our practice to preserve more ureter upper poles and to do lower tract diversions with ureterostomies or ureteropilostomies. I know personally I've had one case in 25 years where I know that there was some loss of function to the lower pole, significant loss with a partial nephrectomy, and that may be one reason why we've transitioned away from doing a lot of partial nephrectomies in St. Louis. Next slide. So what happens after you do an upper pole partial nephrectomy? So if you look at this figure, an upper pole partial nephrectomy was performed on the right side here. And initially there were 10 cases, 10 lower pole reflux, okay? And of the lower pole reflux that was there, 6 of it resolved and 4 of it persisted. And after the partial nephrectomy, because the ureterocele decompressed, the orientation of the lower pole ureter does change. So they actually had 10 new cases of reflux that developed after the partial nephrectomy, and 7 of those new cases persisted, again, because the Trigon had changed. On the other side, new reflux developed or was present, and in all cases that resolved. Next slide. So the question is there any role, what happens if you do a upper pole or simplified approach? So again, at Texas and Mayo, they had a series where they compared incision and upper pole partial in children that didn't have reflux and children that did. So again, if you incise it, it's definitive in only 36%. Why is that? It's probably because you caused iatrogenic reflux predominantly to the upper pole. If you did an upper pole partial and they did not have reflux at diagnosis, then the vast majority of patients, that was the only operation they ever needed. If they have reflux at diagnosis, it was a definitive intervention only in a very small percentage of both of those groups. And again, that's because of the complex anatomy here, where there's eversion of the ureterocele, the trigon's not normal, there's massive reflux. There's no reason to think that removing the upper pole is going to somehow affect the lower pole reflux in this patient. Next slide. So complete reconstruction involves heminephrectomy or moiety salvage. So again, either partial nephrectomy or some ureterocestomy or a ureter reimplant of the dilated ureter, a ureterocele excision, and then ureter reimplant if indicated. And reoperative complication rates, it's a very complex surgery, but there are multiple references in the literature that show that the complication rate in fellowship-trained pediatric urologists' hands is very, very low. So bladder reconstruction, there are basically three ways to do it. You can marsupialize it, or you can reconstruct the bladder base. Next slide. So this is San Diego, George Coplen, Hal Schurz wrote this. So this is surgical managed with preservation of continence, and basically doing an intravesical approach. They incise the anterior wall of the ureterocele. They don't do anything to the posterior wall, and then anastomose the mucosal defect, because both the inside and the outside have mucosa, and then do something to reimplant the ureters. If you look at the small figure in the very left lower hand corner, I think the reason this works in some patients is there's not a hole in the Trigon like there are in some ureteroceles. So I think if you have an intravesical ureterocele, or you have an ectopic one where there was no eversion of the ureterocele during the voiding views, you don't necessarily have to reconstruct the bladder base. Next slide. And again, like I said, this is what I'm talking about here. This is what we've shown before. This eversion, I think, really impacts what you're going to do if you operate at the bladder level. Next slide. So this is out of Campbell's, and in this case, again, you're excising the anterior wall of the bladder of the ureterocele, but then you find the hole in the floor of the bladder, and then you can see in number E there, you've closed the bladder, and I was taught to sort of keel it and really bring it together tight so that there wouldn't get a postoperative diverticulum, and then depending, you either do a common sheath reimplant or a ureterostomy and a reimplant of a more normal caliber ureter. Now, next slide. Extravesically, you can do this if the dilated ureter is out of the way. So if you've done a ureterostomy or a partial nephrectomy, just like we do for extravesical reimplants, you follow the lower pole ureter down into the Trigon, and then you can extravesically reconstruct the bladder, just like you would do if we're doing a diverticulectomy in a single system with reflux and a diverticulum. Next slide. So this article compared, does excision or marsupialization make any difference? And does the surgical choice affect outcome? And the conclusion was, no, it doesn't affect outcome. But I would argue that the surgeons chose to do one method or the other based upon the anatomy that was present. So I think either approach works fine, but it has to be applied to the appropriate patient. Next slide. So again, this is out of Campbell's. If you look at the left side of the graph where they did incisions, if it was intravesical and they incised it, only 114 patients required additional surgery. If it's extravesical and incised it, obviously a larger percentage. Same thing if you did upper tract surgery. If there wasn't reflux, again, like we talked before, reflux and the bladder level anatomy, intravesical versus ectopic is the appropriate term, would manage that. So in conclusion on ureteroceles, I think non-operative management is appropriate in a subset of children with ureteroceles. The simplified or upper tract approach should always be considered in the absence of reflux. Incision of the ureterocele is not a required step in management, but plays a significant role. And bladder level reconstruction is not eliminated by endoscopic approaches. So heminephrectomy, next slide, heminephrectomy, ureterostomy, and ureterocele incision are likely to be definitive in intravesical ureteroceles. Regardless of the initial decompressive approach, bladder level surgery is probably required in at least half of ectopic ureteroceles. Next slide. So it's, my algorithm would be you have a ureterocele, you put them on preventive antibiotics. If they don't have bladder outlet obstruction, if they're not septic, you observe them for a while. And then when they're a little bit older, when perhaps they don't have to be admitted to the hospital past the first couple months of anesthetic risk, then would consider incising them. Next slide. So now we're going to talk a little bit about upper pole ectopia. Just like with ureteroceles, most of these are now periodentally identified. Urinary tract infections are also a source of identification. Sometimes it's discharge in the diaper. The parents will see a greenish discharge in the diaper, so the upper pulmonoid is infected. And then obviously we still, even though most of these are picked up during pregnancy, we still see some potty trained kids who come in with the continuous urinary incontinence. And sometimes it's a little hard to sort out, are they a dysfunctional voider or is it an ectopic ureter? But usually it's a pretty classic history. Next slide. So again, you've seen this before probably. In males, ectopic ureters don't present with incontinence because the Wolffian duct is always proximal to the sphincter. So in a male on the bottom, it's going to insert into the prostatic urethra, the prostate, the seminal vesicles most commonly. However, in a female, the Wolffian duct becomes Gartner's duct, and it tracks along the anterior vaginal wall, and so that's why girls with ectopic ureters can be incontinent. Next slide. Sometimes it's pretty easy to find the orifice. So the ultrasound in these older kids, again, is pretty normal. The kidney may be shorter on the side with the ectopic ureter, but oftentimes you don't see hydronephrosis. And so if you look at the figure on the left here, it's usually going to be if the urethra is up here in the midline and the hymenal ring is there, the orifice is going to be probably about 10, 11 o'clock or 1 or 2 o'clock on the roof of the vagina. And then this is just the retrograde showing the pathetically small little kidney that's making 10 drops of urine that's making her panties damp. I used to think this was the way to go, but I think it's not as easy to find the orifice as you might think. So next slide. So I think the way to really sort this out nowadays is to get an MR urogram. So if you look at the top left picture, you got a duplication on the right side, and that looks to be a single system on the right side. But when you look at more pictures, if you go to the bottom 2 pictures, you can see on the left side there's actually 2 collecting systems. The far bottom right, you see the renal pelvis and then the upper pole ureter. And then you can see on the other view that there's 2 ureters, and then if you look way down, you can see that the second ureter actually bypasses the bladder. So the advantage to the MRU is that you don't have to have function in that moiety. With the T2 images, the fluid's going to be bright, and so it doesn't have to have function to be able to delineate it. Next slide. So the management in newborns is obviously different because there's nothing to incise. So if you had a newborn with an ectopic ureter that was sick, you're kind of stuck as to what to do. And unfortunately, depending on their age, probably a temporizing cutaneous ureterostomy is the way to go, as opposed to an urgent partial nephrectomy. And then you could assess function later. Next slide. The management, though, is pretty much the same. I think you either do an upper pole partial, you do a ureterostomy, or you do a ureteral implantation if it's clinically indicated. Next slide. That being said, if you're in Canada, I think they've described clipping some of these ureters and not doing anything other than clipping them. This is an image from their paper, and you can see that over time, at least on the images they chose to show, that upper pole moiety is becoming increasingly dilated. I don't think this is an absolutely crazy idea. I have to say, recently I was operating on a little girl and was going to do a ureterostomy, and the ureter was crazy small. I could barely get a 0.035 Benson guide wire in the upper pole ureter once I transected. And in hindsight, I probably should have just clipped it, except it concerned me that she had some urinary tract infections, and if there's a few bacteria up there, then that's a problem. So I wimped out and didn't do this, and I did a reimplant of this pathetic little ureter into the bladder, and her continence is cured, and I can safely do a reimplant despite the caliber of the ureter. So again, I think I don't know for sure whether this is a good idea or not. My bias would be if they've had a history of UTIs or they had the greenish discharge in their diaper, it's probably ill-advised because there's probably a few bacteria in there. But I think if they're an older patient presenting with just incontinence and that's never had a UTI, that maybe this is a reasonable thing to consider. Next slide. So lastly, we're going to talk about duplicated systems and reflux. So the question always has been is, what's the resolution of reflux in a duplex system since the tunnel's not as good? So this study was out of DC, and they looked at single systems that they compared to duplicated systems that they had. They tried to match them. They showed that Duplicated systems, about 58% of those with grade 1 to 3 reflux did resolve over time. The mean time to resolution was a couple years. Some children had surgery for breakthrough UTIs because the parents were tired of being on antibiotics. And so their conclusion was, that duplication low-grade reflux can be managed on prophylaxis. Next slide. This was out of Texas. So basically, they took 71 kids with grade 2 lower pole reflux and compared to 71 patients in their clinic that had grade 2 reflux into a single system. And on the left side, you can see the Coplen-Meyer curve that showed, there was some resolution, although there's obviously a difference between single system and duplex system. And actuarially, they went and they figured out if they had actually been able to follow them all 5 years. You can see on the Coplen-Meyer, only 3 patients they followed 5 years there, that 20% of duplex system would resolve at 5 years and 55% of single system would resolve at 5 years. Next slide. So in Toronto, they studied this and they compared a duplicated system with, again, another matched population best they could of single systems. You can see on the graph on the lower left that the resolution rate was much lower with single system, with duplicate system. You have to remember this is all sort of impacted by whether or not they did surgery or not. Surprisingly, most of the patients in the single system arm that had surgery is because the parents were tired of antibiotics. But again, I think if you look at this, duplicated systems do resolve, but it's mostly the lower grades, grade 1 and 2 and 3. So I think there's no urgency to operate on kids like that. And we know that a lot of kids with grade 1, 2, and 3 reflux never end up needing surgery. But I think if you have a duplex system and grade 4 or 5 reflux, the chance of resolution is very small, and you need to talk to the families about possibly intervening. Certainly, this reflux into the upper pole of an ectopic ureter is not going to resolve. So some ectopic ureters that insert into the urethra do reflux, and this is just simply not going to go away. And similarly, this grade of reflux is not going to go away. So we could debate about what the best thing to do about this. I think I ended up doing a ureterostomy on this side, on the left side, on the right side to sew that into normal cavity ureter, and probably did a common sheath on the other side. So I'm very sorry about the technical issues here in St. Louis. We just still have 46 computers and things like that. So I don't have access to the chat. So I don't know if somebody can read me the questions and then we could talk about them.
Yeah, Dr. Coplen, this is Yi. I can read the questions to you. We just have 3 so far, but maybe more will trickle in. 2 of the questions are regarding sort of the optimal age for surgery. One of them specific to reimplantation of ureterocele, and the other just for in general. What's your sort of recommendation for optimal age?
I guess, based on size of baby, typically if I was going to operate on a ureterocele and do a bladder level reconstruction, I want to wait till at least they're a year old. That's not based on any evidence, but the child's just a little bit bigger, and it's I think technically maybe a little bit easier. I typically would like to do it before they're potty trained because I think it's a pretty extensive bladder level surgery, and they're normally sensate, so they have a fair number of bladder spasms and things like that after surgery. So typically, if I sort of knew they were going to need something done, my goal would be to do it maybe between 12 and 24 months of age.
Great. And then the last question we have as of right now is what antibiotic you like to use for your prophylaxis for these patients?
Well, at birth, I use amoxicillin. I have to say I'm a little different than my partners. I think if they're doing great on amoxicillin, especially if they're a guy, I typically don't change it to, sulfa or something at 3 months of age. I know my partners, sort of, oh, we got to switch them to a better antibiotic. But, I think maybe I'm a little bit of a nihilist, but I think if, you get a circumcised boy with reflux and they're doing fine on amoxicillin, typically I'll just keep them on amoxicillin because they haven't had infections. And I think using the least broad spectrum antibiotic possible is best. After they get, if I'm going to switch them, I either use nitrofurantoin or sulfa. Nitrofurantoin is pretty well tolerated, although about 10–15% of kids get nauseous and throw it up and just don't tolerate it. And then I don't know, you're having the same, like now with this COVID thing, I don't know, Procter & Gamble stopped making Puridantin, so none of my kids are on Puridantin seem to be able to get it, so we're having to switch them to something else during this recent event.
There's a follow-up to that. Sort of, how long do you like to keep these patients on antibiotics?
It depends. I think oftentimes if they have reflux and it's low grade, I think it's like any other reflux I have. I'll probably keep them on it till they're toilet trained, or until the parents stop giving it. I think we all have patients that kids come back and they come back for their annual follow-up, and how are they doing? Great. Are they still on antibiotics? No, we stopped it 6 months ago because we were tired of giving it. And if they had any infections, no. So I think sometimes I don't stop it, the parents stop it. But I think I still would, for kids like this that I think are at higher risk of infection, if I don't think that they're going to need surgery because they have very low-grade reflux and the ureterocele is decompressed or whatever, I'll keep them on it until they're potty trained. And I'm pretty sure in my own mind that they're normally potty trained. They're not a dysfunctional voider.
Great. Another question on how you utilize post-op VCUG after the various different surgical approaches that you've described.
So after an incision, I typically don't get a cystogram right away. So if the ultrasound shows that it decompressed nicely, then I would follow them presumably they have reflux to another moiety. I would then follow them like I normally would, and I wouldn't repeat a cystogram for maybe 9 to 12 months, because the cystogram right after the incision, even if it shows iatrogenic reflux, it's not going to change my management. I'm going to keep them on the antibiotic prophylaxis and then just manage them like a regular refluxer, or a refluxer, I guess I would say. They're not regular because I caused it. After a complex, bladder level surgery, I would typically get a cystogram 6 to 12 weeks afterwards. Although I guess some of these kids are complex enough, I've actually left a suprapubic tube in, and I'll get it, 7 to 10 days after surgery. Although I don't leave a suprapubic tube very frequently nowadays. I think I've sort of gone away from that and just leave it Foley and leave it for 2 or 3 days. So I think it's a little different than most times. If I just do a straightforward reimplant, like on a, kid, just do Cohen reimplants on a kid, just a garden variety, fair-skinned, blue-eyed girl that had reflux. Most of those kids, I don't get post-op cystograms. Like I think most people around the country that have shown, based on prior experience, that they can successfully do it. But I think the ureteroceles, and just a little bit, anytime you do a bladder neck surgery and reconstruct something, I think I'm more inclined to want to know, did I do something to distort the bladder neck? What did I do?
Great. Well, Dr. Coplen, thank you so much for an excellent talk. And we have a couple more questions, but I think we're out of time. We'll send those to you so we can post on our website.
Okay, that's you. Okay, sorry about this.
Great, thank you so much.
Okay, bye.